Morning, everyone. My name is Dane Pizzo, one of the PGY2s here. You'll probably know me, but today we're going to be talking about the female athlete triad and its transition to the newer terminology of relative energy deficiency in sports and the current views on energy availability in athletes. So just a list of objectives that I'd like to kind of get through today. First of all, I want to define what the female athlete triad is and its relevant history in the setting of women's sports. I'm going to discuss the transition of the term female athlete triad to its newer terminology of relative energy deficiency in sports, or what I'll likely refer to as REDS. Discuss the various effects of low energy availability on health and performance in the athletic population. And as well, at the end, we'll outline some goals of intervention for athletes with relative energy deficiency. Brief outline of how we'll kind of get through all these things today. Start a little bit with history. We'll move on to the different components of the female athlete triad and REDS, which include but aren't limited to disordered eating, bone health, and a few other systems that we'll touch on. We'll talk about athletic performance, awareness and screening, as well as treatment and some return to play guidelines. So why did the female athlete triad become so pronounced over the last few decades? It wasn't long ago that women were not allowed to participate in organized sporting activities. In the early days of the ancient Olympics, women were excluded from any participation, and even just over a century ago, in 1896, women were still not allowed to participate. It wasn't until 1900 in Paris that they were allowed to take part, but still only made up 2.2% of the total athletic population. Just 30 years later, in 1928, women's track and field events were introduced to the Olympics, but due to collapses during an 800-meter race, they were quickly banned until 1960. A massive step in women's activity participation was then made in 1972 with the introduction of Title IX laws. These new laws made institutions that receive federal funding provide equal opportunity for women's and men's athletic programs. Now, since the 1970s, there's been over a 900% increase in high school women's sports participation and nearly a 500% increase in college sports. For some reference, over the same time frame, there's been only a 15% increase in male high school sports participation. Just a few weeks ago, we saw the United States tie with China for the most gold medals and take home the highest total number of medals. 65% of the gold medals that we won were by women. Now, along with this massive influx of sports participation and pressure on athletes to compete at the highest levels comes health issues that weren't as pronounced in the past. The female athlete triad was first described by the American College of Sports Medicine in 1992 and described as a syndrome that affects female athletes and consists of three components, being disordered eating, amenorrhea, and osteoporosis. 15 years later, in 2007, the ACSM updated their definition to include more of a spectrum, now using the terminology of energy availability, menstrual function, and bone mineral density. Not too much time later, in 2014, the International Olympic Committee convened to update the previous consensus. The new term, now known as relative energy deficiency in sport, or like I said before, what I may refer to as REDS for the remainder of this talk. The update was meant to point towards the complexity involved and the fact that male athletes are also involved. It stands on the basis that decreased energy intake results in impaired physiological function. Since 2014, the IOC has met in 2018 and 2023 and continued to expand and update its view on REDS. The original triad was defined by a combination of disordered eating and or increased energy expenditure, leading to decreased energy availability with result in diminished athletic performance and effects on both menstrual function and bone health. Now expanded to relative energy deficiency in sport, the term is meant to encompass the physiologic functions that low energy availability takes a toll on, and we can see the progression of this advancement in terminology on the bottom of the screen. As I just previously mentioned, the original triad was defined by a combination of disordered eating and or increased energy expenditure, essentially leading to low energy availability and some diminished athletic performance. Now, expanding on what's already included in this definition, we can see the addition of some other physiological systems such as immunologic, gastrointestinal, cardiovascular, and metabolic function. So where does it begin? The physiologic derangements that we see are rooted in an imbalance between energy intake and energy expenditure, resulting in low energy availability. First developed in 1993, now in its third iteration, energy availability is calculated as energy intake minus estimated energy expenditure divided by a person's fat-free mass in kilograms per day. Optimal energy intake has traditionally been defined as greater than or equal to 45 kcals with low energy availability being defined as 30 kcals or less per day. Below this level is where physiological manifestations are said to be clinically relevant. In this situation, this data, which was based on short-term laboratory studies and a small sample of sedentary females, and unfortunately is the benchmark for how we've defined cutoff for energy availability today. The associated difficulties and burden involved in measuring optimal levels in an athletic population makes it difficult to obtain and find exact data or accurate cutoff values for different patient populations. We've seen the components that make up our energy availability. What factors do we typically see in our athletic populations that play large roles in changing an athlete's energy availability? Some of these factors include baseline low dietary intake, programs meant to quickly reduce body mass, and simply an inability to track or keep up with energy intake in the face of extreme exercise commitments. When describing low energy intake, we are faced with one of the foundational elements of the original female athlete triad and now REDS. Disordered eating exists on a spectrum from short-term restricted dieting to DSM-5 recognized eating disorders like anorexia nervosa, bulimia, binge eating disorder, and avoidant restrictive food intake disorder. Combined, these affect several million people per year, and most commonly women between the ages of 12 and 35. When we look at our athletic population, those we can see at the highest risk are the ones in sports that promote weight, aesthetics, and endurance above all else. Now I'd just like to go through a few studies looking at eating disorders in athletes. This first study was published in 2023 and is comparing the risk of eating disorders in adolescent and adult female athletes in Poland. It included 241 highly trained female athletes competing at the national or professional level with an age range from 12 to 30 and a mean age of 21. They were all recruited from different sports, which were broken down into 3 groups, including lean aesthetic sports, endurance and weight-dependent sports, and ball sports. Risk of eating disorder and body satisfaction scores were assessed using a 26-question test defined as the EAT-26, as well as feelings and attitudes towards body scale. Overall, 9.5% of athletes were identified as at risk for eating disorders, 14.6% among the adolescent group and 6.9% among the adult group. Results demonstrated that adolescent athletes in the lean, not aesthetic sports groups, such as swimming, karate, and taekwondo, were at a significantly higher risk for eating disorders. It's important to note that among the 3 groups, this is also the only group that included weight-based sports. Now, this next study was conducted in Norway and included all Norwegian athletes competing at the national level for a total of 938 participants. Of those invited, 186 ultimately took part and were compared to 145 age-matched controls. The age of those included ranged from 13 to 29 years. Prevalence of an eating disorder was measured through a combination of clinical interviews, physical exam, scores on validated eating disorder scales, as well as the use of pathogenic weight control mechanisms such as diet pills, laxatives, diuretics, and vomiting. The table in the bottom right shows or displays a breakdown of the study population. We can see that athletes participating in leanness sports, which are described as sports in which a specific body weight was considered important for performance, had a lower baseline BMI and body fat percentage compared to those competing in non-leanness sports, as well as on controls. This table from the same study demonstrates that although there is no significant difference in eating disorder prevalence between athletes and controls, there is a significant difference between athletes when stratified for their type of sport. 46.7% of leanness sports athletes were found to have a clinical eating disorder compared to 19.8% in the non-leanness sports group. Additionally, comparing these same groups again, we see significantly higher rates of anorexia nervosa and non-specified eating disorders in the leanness sports group. There were just a few other studies that I wanted to take a look at for eating disorders in athletes. Baldo et al. Looked at a group of 124 male athletes competing in a variety of sports and determined that 18.5% of their study population had clinical eating disorders. This can be contrasted with previous studies that showed a prevalence of eating disorders in male athletes at a much lower rate, as under 10%. Additionally, a study conducted in 2013 among adolescent athletes demonstrated an increased rate of eating disorders in the athletic population compared to the controls at 7% versus 2.3%. More specifically, the prevalence among female athletes was 14% versus 3% controls, and in male athletes was 5% versus 0% in controls. So ultimately, I think it's important to note that at the base of the female athlete triad and ultimately RED stands low energy intake. There are many studies out there that have looked at the prevalence and or risk of eating disorders among athletes participating in different sports. What we can take away from this is that although the data is a bit sporadic, showing highly variable rates of eating disorders across genders and athletes when compared to controls, we do see that there are higher rates of eating disorders and risk among athletes participating in certain sports, which include leanness, weight class, and gravitational sports. Now, this does tend to make logical sense, as these are athletes that could theoretically improve their performance overall or in their weight class by lowering their weight. This can be particularly important to remember when evaluating patients in the clinics and identifying those that may be at a higher risk for developing an eating disorder. So far, we've discussed the populations at risk of eating disorders, but ultimately, what effect does disordered eating and low energy and intake have on the body? From here, I think it's important to discuss how low energy affects physiological function and athletic performance. First, I want to briefly discuss the effects of low energy availability on the reproductive system, as menstrual dysfunction was described as a cornerstone to the original triad. To understand the effects on this system, we must first understand the terminology used. In the normal eumenoric patient, menstrual cycles occur at intervals of 28 plus or minus 7 days for the young adult woman. To the contrary, amenorrhea is considered primary if there's been no menses by age 15 in the presence of normal secondary sexual development, or secondary if there is a loss of menses for greater than 90 days after menarche. The bulk of what we will be talking about today in regards to menstrual cycles in female athletes classifies them into one of these two categories. So here we can see a brief overview of the hypothalamic pituitary axis. From the hypothalamus, we have a combination of hormonal and neural input to the pituitary. As a result, the pituitary releases follicle-stimulating hormone and luteinizing hormone, which act on the ovary and ultimately the uterus through estrogen and progesterone. Similarly, in males, luteinizing hormone is also released from the pituitary and travels to the testes, resulting in the release of testosterone. From this moment, we'll focus on the effects of low estrogen and progesterone on the female reproductive system. Amenorrhea in REDS is specifically defined as functional hypothalamic amenorrhea and is characterized by the absence of menses due to suppression of the hypothalamic pituitary ovarian axis. At its core is an alteration in gonadotropin-releasing hormone pulsatility, resulting in a disruption of luteinizing hormone pulsatility from the pituitary and gonadal steroid release from the ovaries. Ultimately, this causes a state of estrogen deficiency and amenorrhea due to estrogen progesterone effects on the uterus. Now that we've discussed two of the three original triad components in disordered eating and menstrual dysfunction, we can move on to what may be the most important to our field, which is the effects on bone health. Before advancing, I want to mention that these three components don't live in a vacuum and actually have a large role in affecting one another. As we progress through the rest of the talk, we'll see how they all work together to have an effect on the athlete. At the most basic level, we have to first understand that osteoblasts function to form new bone, while osteoclasts function to resorb bone. They have a complex interplay, but simply put, one of the most important signaling factors is known as rank L, which is released by osteoblasts and osteocytes. It then attaches to osteoclast precursor cells to activate osteoclasts and begin the process of bone resorption. Osteoprotegerin, on the other hand, functions to bind free rank L to halt the activation of osteoclasts. Rank L production can be affected by a variety of physiologic functions. However, is noted to be influenced by the hormones we just previously discussed about when talking about the reproductive system. So how does irregular reproductive function end up affecting bone health? With abnormal functioning of the hypothalamic pituitary axis, there is a resultant deficiency in endogenous steroid hormones such as estrogen and testosterone. Estrogen acts on osteoclasts to increase apoptosis and decrease rank L-induced differentiation, ultimately resulting in decreased bone resorption. It acts on osteoblasts by decreasing apoptosis and decreasing oxidative stress, resulting in maintenance of bone formation. Additionally, testosterone can be seen to have effects on bone health through both direct and indirect mechanisms. It acts directly on osteoblasts to increase bone formation through the androgen receptor. It can also be converted to estrogen through aromatase and have the effects on bone that were seen on the previous slide. When deficient, testosterone promotes the activation of rank L production by osteoblasts, which in turn acts to increase osteoclast activity and thus bone resorption. So what happens to bone when it's weakened in the setting of low energy availability? When we combine the bone resorption seen in REDS with continued high impact activities, we may begin to see stress fractures in athletes. Stress fractures are defined as overuse injuries that occur when repetitive submaximal mechanical loads exceed bone remodeling capacity. They can be described on a continuum, starting with stress reactions, where imaging may show periosteal reactions or bone marrow edema, and progressing to stress fractures, where a clear fracture line may be seen. One example of a stress reaction early on in this continuum is medial tibial stress syndrome or shin splints. Risk factors include both intrinsic factors such as prior stress injury, sex, body mass index, bone mineral density, as well as extrinsic factors such as micronutrient intake, exercise patterns, and social factors like smoking and drinking. Diagnosis may be made on plain radiographs alone, but they're known to have a low sensitivity in the early stages of injury. It may not be positive until after 3 weeks, and thus MRI is the current gold standard in the diagnosis of bone stress injuries. So here I just wanted to take a quick pause and see if anybody in the audience could kind of talk to me about high-risk stress fractures, particularly why they're determined high or why they're called high risk, what makes them high risk, and what some of them may be.
Like location.
Sure, that's one part. Like certain specific locations that we consider high risk stress fractures.
This,
Yeah, so there's definitely a few. Anybody know like why they're considered high risk? Like what makes them high risk? Okay, right. So high risk stress fractures tend to be in sites with challenging blood supplies or sites that are under a higher tensile load, which essentially make them at a higher risk for non-union. The most common high-risk sites include the femoral neck, anterior tibia, navicular, talus, and the first and fifth metatarsals. And this is important because athletes with stress fractures at these sites may be held out of their sport for longer periods of time and even may require surgical stabilization. So now I'd just like to go through a few studies that analyzed how bone health was affected in certain athletic populations. For the first study, enrolled athletes ran at least 20 miles every week or were engaged in weight-bearing aerobic activity for at least 4 hours a week for 6 months preceding the study. They excluded cyclists, swimmers, rowers, and gymnasts due to variable weight-bearing and potential confounding results. Researchers assessed measures of volumetric bone mineral density of cortical and trabecular bone, as well as bone microarchitecture. Results from the study demonstrated that a larger proportion of adolescent and young adult amenorrheic athletes had fractures compared to eumenorrheic athletes and athletes or non-athletes driven mainly by a higher prevalence of stress fractures. Amenorrheic athletes also experienced fractures later in adolescence when compared to their eumenorrheic athletes and non-athletes. In regard to the relationship between areal bone mineral density and stress fractures, they found that among the amenorrheic group, lumbar and whole body bone mineral density Z-scores were lower in those with a history of fracture and those with a history of 2 or more stress fractures versus those with fewer than 2 stress fractures. They did not, however, find a difference in bone mineral density at the hip or femoral neck, which is thought to be in part due to the weight-bearing effect counteracting the negative effects of a hormonally depleted state. When examining bone microarchitecture, there were no differences between fracture and non-fracture subgroups of the eumenorrheic athlete and the non-athlete groups. However, amenorrheic athletes who had fractured had lower volumetric bone mineral density in the outer trabecular region at both the radius and tibia. Trabecular thickness was found to be lower at the radius, but not the tibia, indicating protective weight-bearing effects. Finally, when comparing amenorrheic athletes who had sustained fewer than 2 versus 2 or more stress fractures, those who sustained 2 or more fractures had a lower total cross-sectional area, total trabecular volumetric bone mineral density, and volumetric bone mineral density at both the inner and outer portions of the trabecular regions of the radius. Additionally, it was found that in the same group had lower stiffness and failure loads at both the radius and tibia. The next study is a large prospective study that was just published in 2024, looking at the rate of bone stress injuries in international athletic championship athletes. Data was collected prospectively from 2007 to 2023 from 24 different international athletic championships. Of the injuries recorded during these activities, bone stress injuries accounted for 1.5% of the total, with a total of 36 out of 2,362 injuries. They broke their data down between indoor and outdoor activities and interestingly found that the rate of bone stress injuries was higher in outdoor activities than indoor, although there was no significant difference found in the rate of bone stress injuries when comparing between male and female athletes. The increased rate of injury during outdoor activities may be due to the length and distance of the events, with the average indoor championship lasting only 3 to 4 days and the average outdoor championship lasting 5 to 9 days. Also, the longest indoor event is 3,000 meters, while the longest outdoor events are up to a marathon in length. So when comparing location of injury, they found that 50% of bone stress injuries were located in the foot, with another 33% being in the lower leg, making nearly 90% of all bone stress injuries being in the lower extremity when you include the ankle. Although the rate of injury in females was noted to be 2 per 1,000 and in males to be 0.9 per 1,000, as I said before, this was not considered to be statistically significant. However, it does line up with previous investigations noting a roughly twofold higher rate of bone stress injuries in female versus male athletes. Also, middle and long distance events accounted for 50% of bone stress injuries, while only accounting for 25% of the total athlete participation. Ultimately, bone stress injuries accounted for a low percentage of all injuries reported during the study, but it doesn't include any injuries that may have occurred outside the time frame from competition, and longer duration studies may be useful in identifying a more accurate incidence rate. This next study is a cross-sectional study published in the International Journal of Sports Nutrition and Exercise Metabolism. They examine energy availability, energy intake, exercise energy expenditure, metabolic and reproductive hormone function, bone mineral density, injury and illness rates, and body composition in a group of high-level endurance athletes during pre-competition training in 2015 and 2016. Female and male athletes were divided into groups of suboptimal and normal energy availability status based on 2 different criteria. These criteria included objective measures of reproductive hormone function and menstrual status, coupled with assessments using the Triad and REDS tools as discussed prior. They also included training diaries over a 7-day course. When comparing body composition with self-reported dietary and training data, amenorrheic females were found to be younger, have a lower protein and fiber intake, and score higher on the Leaf-Q questionnaire compared to their eumenorrheic counterparts. The male subgroup was not found to have any significant differences in dietary intake or body composition between the low and normal testosterone groups. When assessing male and female groups stratified by energy availability, females with low energy availability were found to have lower total energy and fat intake, as well as an increased running load. Males were found to have lower total energy, carbohydrate, and fat intake. As mentioned previously, the study also aimed to examine differences in hormonal and reproductive markers between the groups. Amenorrheic females, not surprisingly, were found to have a lower estrogen and T3 levels compared to eumenorrheic females. They were also found to have lower bone mineral density and SPY and Z scores comparatively. As for males, the low testosterone group was found to have lower T3 levels. When stratified by energy availability, males with low energy availability had lower total testosterone levels. When examining illnesses and bone injuries, there were no significant differences found between groups, but it's important to note that this data is only including illness and injuries over the 12 months preceding the study. When a more retrospective approach was taken, it was found that both male and female athletes who were classified as amenorrheic or low testosterone had a 4.5 times greater incidence of bone injuries compared to the eumenorrheic and normal testosterone counterparts. So this next study, published in the Bone Journal in 2017, aimed to evaluate the effects of low energy availability on bone metabolism in a group of men and women. It was a randomized crossover study including 11 eumenorrheic females and 11 men. Subjects underwent 2 different protocols in which one group was subjected to a balanced energy availability of 45 kcal per kilogram of lean body mass per day, and one group was subjected to a restricted energy availability of 15. Blood analysis was performed to evaluate markers of bone turnover, calcium metabolism, and regulatory and reproductive hormones. A washout period of around 1 month was allowed before repeating the study under the second condition. So unsurprisingly, leptin and insulin levels were found to be decreased in women in the restricted energy availability group. If we turn our attention to the figure in the middle of the slide, we can see a significant difference in markers of bone turnover in women. The black and white boxes represent the control group for men and women respectively, which had an energy availability of 45 kcals. Beta CTX and P1NP are both directly proportional to bone turnover, with beta CTX being released into the blood during times of bone resorption and P1NP increasing during times of bone formation. The dashed black and white boxes then represent restricted group who had energy availability of 15 kcals. From this data, the authors concluded that there was a significant increase in bone resorption and a decrease in bone formation in response to low energy availability in women. Contrary to this, there was no significant effect of low energy availability on bone formation or resorption in men. Also, there was no significant difference in bone metabolic responses between sexes despite altered bone metabolism. So as we've seen with the majority of the studies out there so far, there's a lack of longitudinal data, especially when it comes to male athletes. An article published in 2023 aimed to evaluate a more longitudinal measure of REDs in elite male high school cross-country skiing and biathlon athletes. Indicators that were measured included body mass, peak oxygen uptake, energy availability, body composition, bone mineral density, resting metabolic rate, eating behavior, exercise addiction, and muscular strength. Interestingly, at baseline, 38% of participants had low lumbar bone mineral density scores of a z-value less than 1. Of the REDS indicators measured in the study, athletes had optimal energy availability and showed a slight increase in overall bone health, improved peak oxygen uptake, and muscle strength. At the end of the day, the conclusions from this study are that athletes had an overall enhanced performance and minimal improvement in bone health. What's important to take away from this is that more than a third of the participants had low bone mineral density scores at baseline, and during the period of their lives during which they should be accruing the most bone mass, they had only minimal gains. While this isn't a perfect example of how low energy availability affects bone health, it does highlight how certain athletes may be at risk for not achieving expected bone mineral density accrual during their optimal pubertal years. So I think that I can speak for most of us here when I say that we could use some more sleep. In 1983, 31% incidence of stress fractures was found among Israeli basic infantry recruits. From that point forward, steps were taken over the course of 25 years in an effort to decrease the rate of stress fractures in this population. They made modifications to footwear as well as pharmacological treatments that were not effective in lowering the rate of stress fractures. However, when they lowered the cumulative marching distance and implemented a minimum nightly sleep requirement of 6 hours, they saw a 62% reduction in the rate of stress fractures from 30.8% to 11.6%. They also saw a reduction in the higher grade stress fractures, defined as grade 3 to 4 to 1 to 2, from roughly 50% to below 10%. Unfortunately, the separate effects of reduced marching distance and sleep improvement weren't evaluated, so we're left with wondering if the true benefit was stemming from a synergistic combination or if it's solely the result of increased sleep or decreased marching distance. Either way, decreasing workload and increasing sleep are solutions that can be quickly implemented without a monetary downside in most cases. So now that we've kind of spoke a lot about bone health, I just wanted to briefly touch on a few of the other systems that can be affected in REDS. So first, the cardiovascular system is also known to be affected in times of low energy availability. Multiple studies have shown negative effects on both cholesterol and free fatty acid levels. In a study on a group of dancers with low energy availability, 71% had reduced flow-mediated vascular dilation. This was observed in amenorrheic dancers, as well as in some eumenorrheic and contraceptive-using dancers. Research shows that starvation results in an increased synthesis of lipoproteins contributing to an unfavorable lipid profile. This occurs through increases in lipoproteins ApoA1, C2, E, as well as cholesterol ester transfer protein, resulting in accelerated cholesterol synthesis. There was another study that examined endurance athletes with low energy availability or eating disorders and found that short-term dietary restriction, more specifically 15 kcals per kilogram of lean body mass per day, for a length of 4 days, result in an increased free fatty acid profile. These results demonstrate that dietary restriction may result in an unfavorable cardiovascular risk profile in some patients. Also, just to quickly touch on immune health. Normal immune response can be suppressed by a variety of factors, including insufficient nutrient intake, lack of sleep, psychological and environmental stressors, and prolonged intense exercises. Thus, in the case of athletes, prolonged excessive energy expenditure, especially when combined with insufficient nutrient intake, can predispose to infection. In amenorrheic athletes, it is known that catecholamines, which aid in regulation of immune and inflammatory responses, are reduced, also predisposing to infection. Studies have also demonstrated that mucosal immunity is reduced in weight class sports and those that promote rapid weight cycling. These studies have demonstrated that a reduction in salivary IgA levels, resulting in increased frequency of upper respiratory infections. It's thought that the diminished immunity seen in the setting of low energy availability is an adaptive measure to promote survival by suppressing non-essential processes, but further research is needed to kind of really more precisely define the relationship between the two. Finally, I think it's important to have a comprehensive view of the athlete when screening and treating those at risk for REDS. Part of the initial and continued assessment should include a psychological component. The mental toll of low energy availability on athletes is largely understudied and undervalued in treatment plans. Current data shows that mood changes, fatigue, and psychological conflict may present as an early psychological indicator associated with low energy availability. If left untreated, more severe indicators down the road can include reduced well-being, depression, and eating disorders. The sequela that we see in different body systems highlights the importance of a multidisciplinary approach when we treat our athletes. So far we've talked about kind of what's important from a physician's standpoint, but what about what's important to our athletes? Outside of their health, athletes tend to be most concerned with their performance, as it can be the difference between a starting position and even a scholarship. So the effects we see on sports performance are secondary to the physiological consequences of low energy availability. The maintenance of dietary restriction for long periods results in depletion of glycogen stores and thus results in reduction in physical, psychological, and mental capacity. We can also see an increased risk of dehydration and a higher circulatory lactate level, both of which can result in muscular pain, cramps, and a reduction in fat-free mass. The resultant loss of fat, lean body mass, electrolyte abnormalities, and dehydration may lead to a reduction in muscular strength and thus aerobic performance. So this was a prospective cohort study published in 2014 from Colorado that included 10 national caliber female swimmers aged 15 to 17 through their 12-week competition training season. The goal was to obtain an objective measure of the effects of low energy availability and abnormal menstrual function on sports performance. Groups were split between athletes with normal menstrual cycling and those that were ovarian suppressed, which was measured by serum progesterone levels at 0 and 2 weeks, cyclic estrogen levels, and self-reported menstrual status. Age, gynecological age, and body mass index were similar between the groups. Over the 12-week training season, 400-meter swim velocity and energy availability was tracked for each athlete. In the graph on the bottom right of the screen, we see the energy availability for the normal cyclic menstrual function group on the left and the ovarian suppressed group on the right. It shows that energy intake and energy availability were significantly lower in the ovarian suppressed group compared to the normal cyclic group. In the graph to the upper right of the screen, we can see the effects on swim performance. The normal cyclic group with higher energy availability demonstrated an 8.2% improvement in their 400-meter swim velocity through the 12-week season, while the ovarian suppressed group with low energy availability suffered a 9.8% decline in their 400-meter swim velocity. This study is just one that demonstrates a decline in sports performance in the setting of low energy availability and abnormal menstrual function. I do want to mention that this is also not without its limitations, as there was a pretty small sample size and it was limited to one sport type and one gender. So ultimately, the amount of data out there on the effects of low energy availability on sports performance is pretty limited. Mellon et al. Put together a systematic review of studies examining both the direct and indirect effects of low energy availability on athletes. They characterize their studies as short-term, medium-term, and long-term, with the short-term being defined over the course of days to weeks, medium-term as weeks to months, and long-term as months to years. The studies had variability in their athletic groups, study designs, definitions of energy availability, and primary and secondary outcomes. Some differing results were seen between the studies, but the overall trend of decreased athletic performance was predominant. In short-term studies, athletes had reported decreased counter movement jump strength, power output, isometric leg extension, and 1 rep max bench press. To the contrary, there was one study to report increased vertical jump height, which may be attributed to decreased fat mass in the setting of maintained lean body mass in the short term. Medium-term studies demonstrated decreased explosive strength, eccentric peak forces, and VO2 max. Long-term studies, which are the hardest to measure and we have the least amount of data on, mainly measured self-reported effects and included diminished performance levels, endurance capacity, and response to training. Across the board, athletes were shown to have decreased metabolic rates, well-being, increased injury rates, and physiological dysfunction across multiple systems. Overall, larger and more well-controlled research needs to be completed to fully understand the effects of low energy availability and how it changes over the course of time. So before we can think about treating patients with low energy availability, it's first important to identify these patients who are suffering from it. So Curry et al. Published a study in 2015 analyzing the awareness of the female athlete triad among multi-specialty physicians. They sent a questionnaire to almost 4,000 physicians with roughly 1,000 responses that included questions regarding the components of the triad that we can see on the right side of the screen. A surprisingly high number of physicians were unaware of the female athlete triad. The specialty group that was noted to have the highest awareness rate was orthopedics at 80%, while the lowest being anesthesia at 9%. And only 47% of general medicine physicians were aware of the components of the triad. This study demonstrates that there's an overall low awareness among physicians of the female athlete triad, and there may be many athletes going underdiagnosed and simply untreated due to a lack of awareness. So, outside of physicians, who else do we depend upon to identify athletes who are at risk for suffering from a relative energy deficiency? A study published in 2018 looked to evaluate the awareness of college athletic trainers. A survey was sent to head athletic trainers at National Collegiate Athletic Association member institutions. A total of 235 trainers responded, with 98% of them stating that they were aware of the female athlete triad, but only 33% being familiar with the new term and expanded criteria in relative energy deficiency in sport. Overall, the cohort of athletic trainers was able to correctly identify the main components of the female athlete triad. So far we've talked about physicians and athletic trainers, but what about the coaches who are working with these athletes on a near everyday basis? A study published in 2006, which was well before the emergence of REDS and still in the female athlete triad era, focused on analyzing coaches' knowledge of the triad. A questionnaire was sent to 300 Division I collegiate coaches throughout the United States, which included sports from basketball and track and field to synchronized swimming and Nordic skiing. 91 coaches responded to the survey, and only 41% of them were able to correctly list the different components of the triad. Overall, there's a pretty highly variable rate of awareness of the female athlete triad and REDS between physicians, athletic trainers, and coaches. One of the best ways to treat a disease or syndrome is prevention or early treatment, and this may be an area that we are lacking when it comes to REDS. So with variable awareness rates, we're left with a difficulty when it comes to identifying athletes at risk for or suffering from relative energy deficiency. I just wanted to briefly discuss now some screening tools that are used to help healthcare providers in this area. So a systematic search through PubMed was completed in 2021 to identify questionnaires used to measure low energy availability or REDS in an athletic population. Articles were included if the questionnaires identified low energy availability or REDS risk. This study developed a questionnaire to identify low energy availability or REDS risk, and the participants belonged to an athletic population. From here, 13 questionnaires were identified between 33 articles. Of the 13 questionnaires, 8 had undergone validation procedures, and 3 included questions related to exercise energy expenditure. Of the 13 studies, the most widely used was noted to be the LEAF-Q, or Low Energy Availability in Females questionnaire, which was used in 48% of articles. This questionnaire is validated in female endurance athletes, although is not validated for use in male athletes. A runner-up to the LEAF-Q was the EDE-Q, or Eating Disorder Examination Questionnaire, which was used in 12% of the studies. While it's validated for use in both males and females, it is only validated for those who are considered non-active. Of the 8 validated studies, only 3 are validated for use in males. And of these, only 1 has been validated for use in an athletic population, specifically male road cyclists. As we discussed on the prior slide, the LEAF-Q was the most widely used questionnaire to evaluate for low energy availability and is validated for use in female endurance athletes. It's a 25-item assessment that focuses on menstrual function, bone health or injury, illness frequency, and gastrointestinal function. The EDE-Q, which was the second most widely used, but only validated for use in non-active females and males, focuses on eating behaviors, weight loss supplement use, and body image. As we can see, there's a variety of questionnaires out there being used to identify those at risk for low energy availability in different populations. However, there's no general consensus or single questionnaire that's validated for use in all athletes, including males and females across different sports. More recently, a new 33-item screening tool was developed through collaboration between Australian, Norwegian, Danish, and Swedish centers to assess the risk of low energy availability in male athletes. It was validated through a group of 405 elite and sub-elite male athletes aged 18 to 50, participating in a variety of endurance and weight-sensitive sports. Questions in this survey covered topics such as dizziness, GI function, injury and illness, sleep, and sex drive. Importantly, apart from sex drive, the questionnaire was unable to distinguish between low energy availability and controls, making it suboptimal for use as a successful screening tool. That being said, it does highlight the importance of asking about sex drive when screening male athletes for low energy availability. It also provides a bank of validated questions that could be used for future studies, but still further work needs to be done to create a screening tool that can be used to standardize screening for all of our athletes. So once low energy availability has been identified in a patient, our next goal is naturally to design a treatment plan. However, there's no one best way to do this. Methods to improve an athlete's energy availability are multifaceted and should include a combination of interventions. To do this, we can increase energy intake and/or decrease energy expenditure, but it's also important to treat the effects of diminished energy availability, such as menstrual functioning and bone health. So first and foremost, the easiest way to increase low energy availability is to increase energy intake and decrease energy expenditure. So it makes sense that treatment strategies are aimed to do a combination of these two things. Quantity and quality of data is lacking on the introduction of nutritional interventions to athletes suffering from low energy availability. While nutritional intervention in the form of specific meal plans sounds like a great idea, it's not always the most practical considering the barriers to accurate intake measurement and adherence. A generally accepted treatment plan now recognized by the International Olympic Committee is to increase energy intake by 300 to 600 calories a day, while also including a rest day to a weekly training program. In a perfect situation, athletes may have individualized meal plans created by dietitians, but this isn't considered as practical as simply increasing baseline caloric intake. So newer studies investigating the intricacies on certain diets are starting to come out, showing what macronutrients involved in the diet may have an effect. Fensham et al. Published an article in the Journal of Bone Mineralization showing that short-term carbohydrate restriction increases markers of bone turnover during exercise, even in the setting of optimal caloric intake. So this study included a parallel group design with 28 male race walkers and analyzed P1NP, osteocalcin, and beta-CTX. Specifically, P1NP and osteocalcin are known to increase in the blood during times of bone formation, while beta-CTX is known to increase during times of bone resorption. In the figure on the top right of the screen, we can see the percentage change from baseline of each of these markers of bone turnover. They showed that bone formation markers were negatively affected in the setting of low carbohydrate intake to a greater extent than in low energy availability. Essentially indicating that carbohydrate intake may play a large role in bone formation during exercise, but overall energy and carbohydrate intake are necessary to support bone formation at rest and limit exercise-related bone resorption. So what about treatment strategies for low energy availability associated menstrual dysfunction? Weight gain has been shown to be the strongest predictor of recovery of normal menstrual function in collegiate athletes. However, there are many physicians out there prescribing low-dose oral contraceptives as a hormone replacement option in amenorrheic athletes. While it may aid in the return of menses, it's actually masking the true etiology, which is rooted in low energy availability. There are also more recent data that show specific forms of contraception, such as depot medroxyprogesterone, may have negative effects on bone mineral density in female adolescents. It's well known that bone density accrues throughout childhood and into early adulthood. However, there's a lack of consensus on age at which peak bone mass is achieved. Some earlier studies using DEXA demonstrate peak bone mass all the way into an individual's third decade of life, while others arguing that it happens at an earlier rate. One study using data obtained from Fell's longitudinal study obtained growth data from just over 600 individuals split evenly between males and females. This data suggests that bone mineral density accrual follows a curvilinear pattern between the ages of 8 and 30 years old, with a peak bone mineral density occurring sometime from the early to late 20s, with females reaching this peak at an earlier time. As orthopedists, it always comes back to bone health and how we can improve that of our patients. Current recommendations for optimizing bone health include dietary, exercise, and supplemental interventions. Weight gain has been shown to restore the balance between bone formation and resorption and thus increase bone mineral density. Also, mechanical loading and high-impact sports are known to have positive effects on bone mineral density. It is recommended to incorporate programs of resistance training at least 2 to 3 days per week in athletes who participate in non-weight-bearing sports or those with a decreased bone mineral density. As far as micronutrient supplementation goes, it's recommended that the athlete diet include 1,500 milligrams a day of calcium and 1,500 to 2,000 units a day of vitamin D. Finally, I thought it was worth mentioning the roles of certain medications or hormonal analogs that physicians may be familiar with. Bisphosphonates, which inhibit resorption of bone, are not recommended for women of reproductive age as they're stored in the bone for prolonged periods of time and have shown to be teratogenic. A newer potential therapy being developed but currently lacking clinical trials includes insulin-derived growth factor, which is an anabolic agent thought to increase bone formation. Ultimately, the most important step in management of patients with low energy availability is to increase energy intake through diet, but we can also help support good bone health through mechanical loading and micronutrient supplementation. At the end of the day, and usually the first question an athlete has is, when can I get back to playing? Currently, there are limited evidence-based guidelines to assist healthcare providers and teams with answering this question. This being said, the Norwegian Olympic Training Center and IOC consensus group have developed a model to both assess risk for sports participation as well as guide return to play recommendations. The model is broken down into categories on a continuum from green to yellow to orange and to red. Athletes in the extreme risk or red category should not be cleared to participate and should be seen by and examined by medical professionals. Those in the low risk category are those with healthy eating habits and normal energy availability are given the green light for full sports participation. Yellow and orange risk groups are those that may exhibit some signs or symptoms of low energy availability, however, are not currently considered to be in serious health jeopardy. These groups should be allowed to participate with treatment and monitoring and possible activity modification. To categorize patients, an extensive list of primary and secondary clinical criteria exists in the latest IOC consensus statement. Ultimately, it's up to us as medical providers in conjunction with our athletic trainer and coaching colleagues to help identify athletes at risk for and appropriately treat them and get them back to playing. So aside from a guideline of return to play, I just wanted to provide a sample rehab guideline for athletes that could be suffering from stress fractures in the foot, which is one of the most common locations. This is a 4-phase rehab guideline developed by Sanford Health that outlines treatment and progression protocols for athletes with stress injuries to the foot. Phase 1 consists of the acute injury phase from 1 to up to 4 weeks. In this phase, the goal of care is to remove stress from the site of injury through casting, splinting, or booting, work on range of motion, and improve pain. To advance to phase 2, athletes must demonstrate no pain with palpation and pain-free activities of daily living. Phase 2 is considered the subacute phase and is typically from weeks 4 to 6. At this point, the goal is to initiate slow return to activity by starting at less than 50% of the prior training volume and slowly increasing. To advance to the next phase, athletes have to be able to demonstrate the ability to single leg hop, extended walk, squat, and heel raise without pain. So on the back end of the rehab guidelines, we have phases 3 and 4, which contain weeks 6 to 10 and beyond. At this point, athletes are continuing to increase their activity levels with a return to running and normal recreational sporting activities. Once they can demonstrate pain-free completion of a running program, they're cleared to return to full activity. As I mentioned before, this is just one example of a rehab guideline for athletes to return to play. And every physician out there typically has their own version of this. So thanks for bearing with me through my talk. In case anyone missed anything, I just wanted to give a brief interview of kind of what we went over. So since 2014, the IOC, or International Olympic Committee, began a transition in the term female athlete triad to relative energy deficiency in sport. The new term has been meant to emphasize the fact that females are not the only population affected by low energy, and we can see the effects of low energy availability through multiple bodily systems. Most importantly to us as orthopedics, we can see an effect on the bone health of our patients. We may see a higher incidence of bone stress injuries and diminished performance levels in athletes that we care for, and we're the ones tasked with getting them back to play. Surprisingly, there's a low awareness level of the female athlete triad and an even lower awareness of its new terminology of REDS. Going forward, it's important to educate providers caring for athletes on the signs and symptoms of low energy availability, the current views on treatment, and guidelines on return to play. Just one final aside that I'd like to make is that orthopedists, we aren't just caring for these patients as they're young and presumably in the healthiest stages of their lives. we continue to see an ever-growing aging population presenting with fragility fractures, and it's been estimated that just a 10% improvement in bone mineral density at a young age could reduce the risk of fragility fractures during adulthood by 50%, which would really highlight the importance of bone health to all providers. Over the next several years, we can hope to look forward to advancements in screening tools, definitions of newer terminology such as adaptive versus problematic low energy availability exposure, and standardized treatment programs. So here I just have a list of my references, and thank you everyone for bearing with me through this.
Thanks for presenting that information. It's a lot of stuff. As an orthopedist, our concern is mostly with stress fractures. We only see these people when they have a bone injury. So at the end of the talk, it's a bit confusing. We always thought that this terrible triad in women, was significantly related to these stress fractures. And it was hard to tell through the talk because they changed the terminology. Understandably, everybody has relative energy deficiency. Are these female problems, amenorrhea and eating disorders, psychological eating disorders, not the one that a wrestler has when they want to make weight? Are these or are these not significantly associated with stress fractures compared to the population that doesn't have those two things?
Are you saying specifically with females with eating disorders, or sorry, are you saying females with eating disorders or females with like amenorrhea?
The triad of amenorrhea and bulimia, say, that with stress fracture, is that association with amenorrhea and eating disorder, is that association increasing the risk of stress fracture significantly, or are we seeing the same risk of stress fracture in the regular population?
Yes, we are seeing an increased risk of stress fractures in females with lower energy availability, and that I think the original triad that you're referring to, it's based on a continuum, and all these factors kind of play a role in the total effect. So kind of an eating disorder can lead to kind of having a low energy availability in females, kind of resulting in abnormal menstrual function and low kind of endogenous hormones like estrogen, which, estrogen is one of our primary steroidal hormones that kind of help to improve our bone health. So yes, at the end of the day, we are seeing an increased rate of stress fractures in females that are suffering from a lower energy intake and availability.
What you're doing is it's very confusing. A lot of people don't take enough energy in. The question is, are these additional factors, amenorrhea and eating disorder, the ones that have a diagnosis code that you can put to it, like bulimia, are they significantly increasing the risk compared to the general population that just doesn't take enough intake?
Well, so I think that's kind of the point of the talk, is that it allows us to recognize that it's not just patients with eating disorders that are having problems. It's actually everyone who has lower energy availability, whether it's because of disorder eating from a psychological standpoint, or whether it's because they're just not keeping up with the load that they need to. So the point is that all of the patients who have the low energy availability, so I think Dane is trying to get us to change our terminology, because if we only focus on patients who have psychological disorder eating, then we will miss a lot of patients who we can intervene on, because we're not looking at it. So expanding our terminology is hoping to expand the number of patients that we capture, take care of, and get better.
Yeah, very hard to hear. Very hard to hear. But the question really, who's most at risk? It's understandable that everybody's at risk. Just like a hip fracture, everybody's at risk for getting a hip fracture, but older women with osteopenia are at an increased risk. And so those are the people we concentrate on. So if
So does the terrible triad exist underneath the umbrella of this Reds description, or has that been replaced by Reds?
Sorry, can you repeat the first part of your question? I didn't hear. There were two people saying.
The triad been replaced by red.
Yes, yes. So the triad has been the terminology of the female athlete triad has been transitioned to the newer terminology of relative energy deficiency in sports. It's kind of it's a relative energy deficiency in sports is you can think of as more of an umbrella term that encompasses REDS. So yes, we use that new term REDS when talking about the female athlete triad now.
So then in all of your questionnaires, there's a whole big section on amenorrhea.
Correct.
Making it sound like guys have amenorrhea.
No, that's why a lot of the questionnaires are validated for only certain patient populations. So there are certain questionnaires that are validated for use in female athletes. And one of the points that I made was that we don't really have a validated questionnaire that can be used to assess athletes of across genders and across sports. So yes, I agree that there are screening tools that specifically focus on menstrual function, but those screening tools specifically are validated for use in female athletes, not males.
So in the sports clinic at Rutgers, you guys go, there's always a resident there, there's an attending. The same number of stress injuries occurs in male and female. Is that what you're saying?
I don't think that's what I'm saying. No, I think that what I'm saying, well, first of all, I haven't been in the sports clinic. But what I'm saying is that originally this was defined as the female athlete triad. And by that terminology, thinking that only female athletes can suffer from stress fractures when suffering from low energy availability. The newer terminology and kind of what we were talking about was that this is now expanded to realize that it's not just females that are affected. While females may be at a higher incidence rate of stress fractures, still, they're not the only ones that are affected. So males can be affected just as females can, maybe not to as high of a rate, but it still happens. So as far as how many, stress fractures our attendings and residents are seeing in the sports clinic between females and males, I'm not entirely sure of that incidence rate.
Don't you think that's the most important thing, to be able to lump them all together? I mean, we're trying to pick out people that are problematic, and,
Yes.
and you're now including them all and lumping them all in one. It used to be, at least we were taught, that this is a significantly higher risk of getting a stress injury. And so we were very careful to, look at this, and now you're lumping it all together. It just doesn't make sense.
Yeah, I mean, we've always known that men can get stress fractures, and as a percentage of the athletic population, the rate in women has always sort of been higher.
Yeah.
Which I think why we teased out this idea of what's going on with women that we don't see in men. And I don't know that. I think so. My problem is I still think it should be, and you've already addressed this, but we still need to treat the women a little bit differently. The questions have to be different, and the your radar has to go up a little bit higher when you see that those scenarios coming together. A question that I had for you that rates back to the treatment, you have this algorithm and the treatment pathway, and it's always been a long drawn out process, and it's longer for some kids than others. And you mentioned insulin growth factor as being, a potential treatment. Is that designed to shorten the course of that? Are we going to be able to treat people with different growth factors and get them back earlier? Is that what the idea is, or is this more of a prevention?
I believe it was more of a treatment. I don't think that we were looking at, or I don't think that the studies were looking at giving it as a prevention, more so as a treatment. But it was also just very briefly mentioned as kind of something that's looking at, or to look at going forward. There really aren't any clinical trials using that as of just now. But I believe that it's meant as a treatment, not a prevention.
And you a very comprehensive review, and I was always wondering why research doesn't look at high school and collegiate wrestling, because there's an athlete who basically tried.
Can't hear you really well. Can you guys have a mic there?
Yeah, I'm talking into the microphone.
Oh, all right. Sorry.
The best I can do. But how come wrestlers aren't a focus of research? Because they cut weight a lot. And they compete at a high level, but then if you follow them through their career as wrestlers, at least post college and wrestle either at the Olympic or international level, they stop the whole weight cutting thing. And they all say that they're better athletes when they stop training weights. With all these, physiologic markers you went over, did you see anything about wrestling? No.
Yeah, so I think that one of the
And also
issues,
one of the things that the number of females going into wrestling is rapidly growing in the United States. There are 2 girls that are on scholarship for collegiate wrestling. So you're gonna see more and more females in wrestling. Kind of interesting to see what happens going forward. You look through so much data, I want to see if you come across wrestling at all.
yeah. So I think that one of the issues with some of the studies is, as we talked about it, a few of them specifically mentioned, race walkers was one of them, endurance athletes was another, and some of the other studies kind of just lumped sports together as groups. So weight or wrestling was included in a few studies, but it was never looked at specifically. I think one of the factors about wrestling that make it a little bit more difficult is it's a like a weight cycling sport where athletes are kind of dropping their weight on a weekly basis sometimes to make weight and then gaining it all back. And this thought of or one of the last terms that I mentioned at the end of the presentation was kind of the exposure to low energy availability. So are you having a low energy availability for a short period of time versus having it for a long duration of time? And I think that wrestling is one of those sports where, like I said, it's a weight cycling sport. So you may be at higher risk if you're at a longer exposure, which I think wrestlers are. But particularly, there was no study that particularly only looked at wrestling as at least that I came across.
I don't know of any at all. It's not always been there's a curiosity of mine. Maybe going forward, again, you say wrestling is a weight cycling sport, but you watch sports and sports specialization now. Kids who decide I'm gonna be a wrestler, they wrestle year round.
Yeah.
Yeah, so there's they pitch year round and they do all these other things year round. Wrestling is kind of making a bit of a comeback, especially as the female population starts to grow. Maybe we'll see something interesting in the future.
Yeah, I agree. It would be interesting to see something that particularly just looks at wrestlers. And like I said, they were included in the studies, but they were never stratified just by that sport type.
Most of our athletes who's really don't know that sport. So they see wrestling, etc.
That's a great question. I don't know the answer to kind of what our current athletes' diets look like, since I haven't really been face to face with any of them. And any of the articles that I looked at didn't actually comment on what the actual athlete's micronutrient intake was. There was one study that I mentioned that looked at kind of carbohydrate intake in particular, but there was nothing that I came across that was particularly looking at micronutrient supplementation. And I think it's particularly difficult to assess because a lot of these studies are using just kind of self-reported intake diaries. And, you have to really trust somebody to accurately report what their intake is. And especially when it comes to micronutrients, that can be a little bit more difficult. So I don't know kind of what the status of our athletes' micronutrient intake is, but I think that it is something that we can incorporate supplementation for at a relatively kind of low risk. Thank you, everyone. So now we'll